Good afternoon, everyone. Welcome to our next session in our Boosters and Beyond Addressing Key Challenges series. Today, we're going to be talking about the CDC's core infection prevention practices as it relates to leadership. So if you're not familiar with who we are the IPRO QIN-QIO. Specifically, IPRO holds the contract for the Medicare QIO contract for the region shown here. Specifically, IPRO helps support New York, New Jersey, and Ohio. Health-centric advisors help support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarence helps support Maryland, Delaware, and the District of Columbia. Together, we are three companies under the IPRO QIN-QIO banner. So if someone asks you if you're working with IPRO or if you know who IPRO is, you say yes. And we always start our series sessions with a COVID-19 vaccine update. So with that, I'll pass it off to Mary Ellen Casey.
Thanks, Josh, and hi, everybody. Hope everybody had great holidays. I feel like we're zooming through January. Little update on COVID. Our hospitalizations are down 12% this week. The 7-day average is a little over 5,000 hospitalizations, which is sort of a collective sigh of relief. Bivalent boosters, we have almost 50 million folks who have received an updated booster dose as of the 11th of January. But that only translates to about 40% of adults 65 and older that have had an updated bivalent booster. So certainly moving in the right direction, but can do better for sure. The latest variants as of the 14th of January, the XBB 1.5 that we've been hearing so much about has taken the #1 spot for most current strains circulating, followed by BQ1.1 and BQ1.1. Interestingly, wastewater surveillance continues to trend BA5 and BQ1.1 as the dominant strain. So I guess the bottom line is really the booster vaccine is still effective in offering protection against these variants. Next slide. It's a snapshot of the NHSN data reporting older adults, nursing home residents that have received the updated booster, and we're ticking slowly in the right direction. I think last week I reported we were at 47%, we're at 48%. So we are moving in the right direction. This is where the grinding, kind of walking through the sludge work is happening. Next slide. This is an interesting article that came out in the New York Times, and I'll pop the link into chat if you want to read more about it. Really kind of looking at the daily average US COVID patients that are hospitalized. And, a picture tells 1,000 words, right? So here we are, January 12th of 2023, where it's more like a bump instead of a surge as compared to what we recall in 2021 and 2022, which was just terrible. But it does not look like a comparable surge is going to materialize at this for the winter, which is great. And so data would suggest that although we're seeing a bit of a rise right now, this is not the surge that we've had in the past. And hospitalizations, again, are much lower than anticipated, which is great news. Next slide. Of course, if you're in different areas of the country, it's a very different picture. Here in the Northeast, the variant that we're seeing that I just mentioned is really taking off in the Northeast, not so much in other parts of the country. So you can see definitely, depending on where you live in the country, that it's a very different picture with what we're seeing for COVID numbers. But that being said, we're still seeing an improvement across the country as a whole. And there's a couple of reasons for that. Next slide, please. So population immunity, we've heard about this herd immunity, since the vaccines came on the scene. But the actions that people have taken have suppressed a winter surge. That's really the bottom line. It's a lot of things, primarily the vaccine. As much as people, there's still a lot of hesitancy with the booster vaccine. That vaccine has been the single most effective tool that we've had to really squelch some of these surges that we've seen. In addition, people who have had infections, that's played a significant role too in increasing herd immunity. But I would also say that people are still practicing good infection control measures, whether it's, we may never see a mandate again as far as masking, but people are feeling comfortable enough to mask where they feel that there's a risk, whether it's in bigger groups of people. Hand hygiene is still part of people's preventative measures. So all that has really helped to really prevent what we thought was potentially going to happen. I will say, though, that just keep in mind, for the older adult, they are bearing the burden of hospitalizations and deaths. Even today, the majority of hospitalizations that we see are in older adults, and the majority of folks that are still dying from COVID daily are in the older adult category. So it just reminds us to be vigilant with our efforts still. Influenza update, also good news, activity continues, but it is declining in most areas. The strains are the same. The vaccine continues to be a good match. The numbers are increased, but that being said, they're starting to see a decrease in hospitalizations as compared to last week. Antivirals are still effective against the current strains, and I'll pop this link into chat. HAN alert, which the CDC puts out if folks get these alerts. Tamiflu, for some folks, has been difficult to get. So this HAN is just a document and recommendations on how to prioritize antiviral therapy should you have trouble getting Tamiflu, depending where you are. And that's it. Back to you, Josh.
Perfect. Thanks so much, Mary Ellen. So today's topic, we're going to be looking at the CDC's core infection prevention practices. And the first one of them is related to leadership and support. I've outlined them here. Number one, ensuring that the governing body of the healthcare facility or organization is accountable for the success of infection prevention activities. Number two, allocate sufficient human and material resources to infection prevention to ensure consistent and prompt action to remove or mitigate infection risks and stop transmissions of infections, as well as ensuring that staff and resources don't prevent nurses or environmental staff, etc., from consistently adhering to infection prevention and control practices. Number three, assigning one or more qualified individuals with training in infection prevention and control to manage the facility's infection prevention program. And number four, empowering and supporting the authority of those managing the infection prevention program to ensure effectiveness of the program. So taking a look at this first glance, you can actually just see written between the lines that all of this is pretty much required already from a facility standpoint and regulation. So we're going to have Dave talk a little about how you can get familiar with that. And then Margie is going to take us into actually putting this work into practice. So over to you, Dave.
All right, thanks, Josh. When we speak about infection control, I just wanted to talk a little bit about the requirements, because anyone who knows me knows that I always point to the requirements, and simply put, these are not recommendations or suggestions, but the regulations that are detailed in the State Operations Manual. That's commonly known as Appendix PP, or the Guidance to Surveyors for Long-Term Care Facilities. And I oftentimes refer to anything regarding Appendix PP as an open book test, because it truly is all laid out for you. Again, you may not like what you see, but these are the requirements. The latest version of Appendix PP is 856 pages. And it's available at no cost as a downloadable PDF that really allows you to carve out the sections to print or share electronically with other members of your team. For discussion today, we are focusing on the 483.80 infection control portion of the manual, and that's currently over a little bit over 50 pages. Next slide. Just on this slide, I did just a simple search, a screen print to show you the Google search page where I entered Interpretive Guidelines Appendix PP. And you can see that in this case, the very first listed item is titled State Operations Manual Appendix PP. and it directly references CMS in the download link. Now, at other times, you may do the same search and some other reference documents may pop up, say, for example, something from a trade association or from a legal firm, but I suggest that you focus on the entry with the cms.gov reference in the link. That will take you right to the original source document for you to download. Next page. When you first open the downloaded file, you'll see this index page. And as mentioned earlier, our focus for this call is on section 483.80, infection control, as shown in the lower section of this index page. Next slide. Within section 483.80, there are specific subsections that you may be a little more familiar with, those being what are commonly called the F tags. These specific subsections include F880, infection control, F881, that speaks to an infection prevention and control program, as well as the requirements for an antibiotic stewardship program. F882 is specific to the requirement for an infection preventionist, and finally, F883 details the influenza and pneumococcal immunization requirements. Next slide. Each section, on this slide, I'm showing you each section is laid out to include the intent of the regulation, any key terms used within the section with specific definitions for those key terms, an overview of the section, and they obviously call that the guidance, any investigative protocols used by the surveyors to determine a facility's compliance with a particular section. There are also examples of key elements of non-compliance that are used to cite any deficient practice. And finally, specific deficiency categorizations with examples of the 4 deficiency levels, from no actual harm with potential for minimal harm, known as level 1, up to level 4, or commonly known as immediate jeopardy. Next slide. Section 483.80 starts with an overarching statement or foundation that I'm going to quote for the sake of this slide. The facility must establish and maintain an infection prevention and control program designed to provide a safe, sanitary, and comfortable environment, and to prevent the development and transmission of communicable diseases and infections. Next slide. Your facility's infection prevention and control program must include a system for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases for all residents, staff, volunteers, visitors, as well as any other individuals that you have under contractual arrangement, based upon the facility assessment as detailed, and that's detailed in section 483.70E. And of course, all of this has to follow what they commonly call accepted national standards. Now I'm going to pass it off to my colleagues, where they will provide you with a little more detail specific to the management support of your infection prevention and control program. Josh?
Sure. So we've looked at the core infection practices from the CDC and reviewed how we can see all the requirements within the state operations manual. So, okay, we have the requirements. We know what the core infection prevention practices are that the CDC suggests. So what do we actually do as leaders and managers to help support the infection prevention program? Because we know that infection control is not just the responsibility of the infection preventionist. And I actually have Margie here that's going to be talking about ways leaders can support infection prevention within the facility. Margie, over to you.
Thanks so much, Josh, and thank you, Dave. what I want to share with you, Mary Ellen and I have been tromping across New England and across the IPRO region. Folks have been adopting a special program called the Shift Coach Program. And that last slide that Dave was talking about, that talked about your program has to include these specific things. One of the wonderful things about the Shift Coach Program is that it wraps all of that into one very specific project. And I'd love to tell you about it because we've seen great results from DC all the way up to Maine. There are homes that are adopting the Shift Coach program. And I'm going to tell you a little bit about that, but more importantly, how leaders have been going through the program and becoming real advocates for it. And so right here is one of my favorite of our folks. This is an administrator named Michael Skase. He runs a very large nursing home in DC. And in real life, Michael is a champion of the Shift Coach program. I'll just say Shift Coach program began as a pilot with Brown University and the Connecticut Department of Health. A gang of nursing homes became pilot testers of the program. And what it essentially does is it invites the infection preventionists to develop a small army of shift coaches who help kind of keep an eye on infection prevention within the building. It carries a see it, say it, solve it philosophy. And that's what makes it really all come together. Let me tell you a little bit about what Michael did in order to make the Shift Coach program work. Next slide, please. What Michael began with was he was a man with a mission, and he had a very special way of making sure that staff understood the why it's so important to be doing this type of work, preventing infection and helping people to understand how things have changed over the last 3 years and how important infection prevention has become right up front, and that each home has to really have a wonderfully structured program to ensure that all throughout their organization that things would work really well. Mary Ellen, anything you just want to add, having just recruited a whole gang of nursing homes?
Yeah, I would say, one of the first reactions infection preventionists have to it is, oh my goodness, more work. And it's not, as Margie mentioned, it's really an army of folks that extending the IP's reach. It's timely because we all know that COVID has put unprecedented demands on IP's time. And this program really helps to sort of spread the word about what the IP wants done and have support around it.
It's a share the love program, Mary.
Yeah, share the love program.
Share the love. Josh, can you show us the next slide? Because it kind of helps us to walk through. This is kind of how it works. Leadership, guys like Michael Skase, great administrators, along with the IP and the director of nursing, identify some folks who will make great shift coaches. Then the shift coaches go through training so that not only do they kind of up their game as infection prevention eyes and ears, but they also become great observers, and they report and offer just-in-time training. Right when they're seeing something in that moment, they serve to go over, offer some suggestions. And I think the famous statement we use all the time, Mary Ellen, is coach, not cop, right? So not to stop people in the moment, but just to offer them some coaching in that moment. And then they record their daily observations. Each day they gather really quickly and do a quick huddle where they talk about the things they're seeing. They say it in the huddle, let people know, and as much as possible, they try to solve it. They get the maintenance guy to go change where some hand sanitizer is, or maybe fix something in somebody's bedroom so that it's not an infection issue. Those huddles are kind of the glue that hold it together. Identifying solutions happens right in that moment. And for bigger ticket items, those things are put onto the QAPI committee to actually work through. There's a little tracking tool. The IP reviews the data and just keeps an eye on trends and make sure those things are happening. And then, of course, the team celebrates. Key to the story, though, on the next slide, you'll see, is that the team actively supports implementation and observation and monitoring and acting on data, troubleshooting and, finding solutions for the things that are going on. The next slide, though, shows you how guys like Michael Skase are actually able to support this whole idea. One thing Mary Ellen and I are quick to reference is the fact that this isn't like a one-off. This isn't some like new project and hopefully it'll go away in 4 months. This is actually the new nursing home way. And so guys like Michael are leading the charge, helping people to really understand why it's so important and spending lots of his time ensuring that outbreaks don't happen, because it's not just the infection preventionist job. In Shift Coach, guys like Michael Skase are able to show how it's everybody's job and gets everybody involved in the process. Next slide. So what some of the leadership have done in the Shift Coach homes is that they familiarize themselves with the Shift Coach program. They begin to implement a plan to actually get it going. And then they actually go ahead and do a lot. They kind of point out some staff who might actually make good recruits, but the infection preventionist gets to pick. But one of the really important things that happens is rounding. And so great leaders are out looking around, seeing what's happening and mitigating some of those challenges along the way. Next slide. One of the things that has become a really effective way for administrators, particularly in helping with the whole infection prevention process, is by actually going around and rounding all throughout. Putting a date on their calendar is kind of key, because you can get really swept away into the details of the day, putting out fires, running around, doing things. But this has to be a calendar appointment. Great thing to do is to pick up somebody along the way to round with you and to be able to ask important questions, keep an eye on things. Here's the catch. You're not there to find out who's doing what wrong. This isn't kind of a punitive type of thing, but instead it's more about being out and about and talking with staff to understand why. Do they get the why and how things are going? And so we talk about the 80-20 rule, and the 80-20 rule is that other people talk 80% of the time, and you only prompt with questions just 20% of the time. And that becomes a real key thing about that. Mary Ellen, anything on rounding that you want to add?
I would just say, it really, it's an eye-opener, I think, for leaders, as I'm sure most people know, an eye-opener for them to round on the floors. And actually, the nice thing about this program is, and Margie gave the example of Michael, he rounded on the floors, but he also made it a point to spend some time with the shift coaches, sort of getting their input and finding out what they were seeing. And the other thing I like about this program is the fact that, again, the IP is trending some of the issues that may be common across the units. And so it can really help to guide education reinforcement. It's not about pointing fingers. It's really about establishing patterns and then being able to come up with a plan, an education plan, and implement that. So.
Yeah, and just in case you're interested, we gave you the link in the chat so that you can take a look. Some of the things have changed, but the basic content is the same. Next slide. The other things that a lot of the administrators who have been part of the program, when they're rounding, they also work to mitigate negativity. And I think right now we're in a place where, because people are working so hard and because of kind of the state of things, I think there's a little bit greater propensity toward kind of the negativity and whining. And so what we've seen is that people are playing a really key role in talking with folks, dealing with those comments, not blowing them off, but listening to folks and seeing what kinds of things they can do to kind of help out and diminish some of that negativity along the way. Next slide, please. Some of the things that administrators can take in time to advance their craft along the way, you know, people will be jealous of some of the coaches. That can happen, and so they talk about some of that. People don't see the need for change, which you know, change is inevitable. So helping to work through a change process with staff. Sometimes people will express that it's more work, but like Mary Ellen said, it actually helps to you've spread the load out across every unit by having a shift coach, and then that information is captured by the IP, making it so much easier, you know, because it's tough to be the eyes and ears all by yourself. The Lone Ranger thing isn't working when it comes to infection prevention. And people will say it doesn't make a difference. And yet, in all honesty, we've already seen results that are showing that it really does. So administrators in leadership can really make a difference in helping to turn that conversation around. Next slide. What we know is that when we start addressing attitudes right up front and being real upfront with folks and letting people have the conversation, that it can make a huge difference. Attitudes is one of the strongest elements in determining if staff will consistently implement what they learn. And so, you know, when they're out on the floor or in education programs, their attitude and their positivity is going to make all the difference. Next slide. So just to kind of give you the big picture, leadership listens, encourages, and supports. And that's key to infection prevention. If you want to know how to do all those things that are in the regulations, we really suggest, you know, rounding and promoting infection prevention practices and highlighting the why, you know, why it's so important. Turns out, Mary Ellen just showed data, and it turns out it's people over 70 that are dying in the midst of this pandemic. And so we're protecting that entire population. So it's incredibly important. You know, recognizing staff publicly is what administrators do well. Incentive demonstrations of good practice, incentivizing those types of things, participating in daily huddles, and making rounding a calendar appointment every couple of days, if not every day. Next slide. So any questions? Over to you, Josh.
Yeah, does anyone have any questions about the ICANN program from Brown that we talked about? We reviewed the core practices from the infection prevention and how you can see all the requirements within Appendix PP in the State Operations Manual. A lot of times it can be difficult to think about how we can actually put these regulations into practice from a leadership standpoint to help support the work of the infection preventionists. So we're hoping that you saw some value in the ICANN program that Margie had discussed and ways you can go about doing that. But do we have any questions from the audience? Anyone want to come off mute or put it into chat? While we have people doing that, I just want to highlight some takeaways from today's session. So we want to empower our infection preventionists, whoever's in charge of the infection prevention program, to have the authority and ensure effectiveness of the program itself. Use different methods like shift coaches, huddling, rounding to help support them. You want to help reinforce their messaging. You're still the administrator or the director of nursing. So the facility is going to be looking to you for leadership, and you need to be supporting the infection preventionist messaging and work to make sure that everything's getting done as a united team. Again, infection control is not just the responsibility of the infection preventionists. And another consideration too is time allocation to get the job done. So many infection preventionists wear multiple different hats So does your infection preventionist have the time needed to get fully support the facility and meet all the requirements? There's actually some language in the regulations to ensure that the facility's infection preventionists must meet and support the entirety of their facility. So making sure that they're able to effectively do that is your responsibility as a leader. Here is our contact information. If you'd like to talk about any of this further, we'd love to hear from you. And that will be it. I don't see any questions in chat or anything, but that'll be it for today's session. Since there's no questions, if you thought that today's session was beneficial and worth your time, we'd love to hear feedback from you before you head out. And with that, that'll be it.